Does that come up all right? Cool. Okay, wonderful. Yeah, so good afternoon, everybody, or good evening, I should say. This is the first part of the lecture series for immunology that we're going to be doing. It's going to be a four-part series. And this is my information here. I put an email address down here. It's an active email address. Any questions you have about today's lecture, anything else going forward from your notes, from the text you're reading, just feel free to ask me. And as far as these four lectures are going to be, they're meant to be a companion to the coursework that you have online, as well as your book. And what I'll do is before next week's lecture, I'll post the syllabus for the course, which will have some clear objectives, kind of what I'd like and what we'd like for you to take out of the course, as well as information about the required textbook, required readings, etc. Um, so moving along, what I'll do is we have four lectures for immunology. Um, to be honest, immunology I think is one of the most difficult courses, just in general. It has a lot of information. It's built on a very complex and abstract vocabulary and just understanding of how different processes within the body work. It's quite complex, but the good part is that we have a certain understanding that we want you to get out of it from the four lectures from your work that you do at the university. So rest assured, it could be much worse, but we have a specific focus here. And so with this first lecture, what I want to do is this one will probably be the shortest out of the four. I kind of want to just lay a groundwork for everyone here. I want to give an overview of the immune system. That's where we're going to spend most of our time. We're going to look at some of its structure, its organization, some of the key players as far as an organ system, even if you want to call it that. And after that, we're going to go into innate versus adaptive immunity, very commonly tested. And then we'll end with the MHC, or the major histocompatibility complex. And so today, like I said before, I just want you to take away an overview. So much of immunology is based on vocabulary. There's just a ton of, especially if you've been studied before, there's a ton of vocabulary you might not be familiar with. And what I prefer to do is kind of as we cover the material and as we come across that vocabulary, I'll make sure to kind of present it. And just the other thing I want to say too is that immunology is one of those courses where it's really about constant revision. You can find yourself that you've put in time to study it, to read it, to do questions. But then if you wait, it's like a muscle, and the muscle can get smaller if you don't work it out. So it's a course where it's very common. Revision is always part of the game here. So just as you move forward in the course, just keep that in mind, how much that comes into play. All right, so I want to start here with, what is the immune system? Really, what the immune system is it's composed of many different cells, organs, proteins, a lot of key players here. Oh, we got one more. Okay, hello, Dr. Enzo. We got a ton of key players in the immune system: cells, organs, proteins, and essentially what the immune system does is it plays a key role in the body's response to infection. It can also play a role in trauma, in cancer, anything the body might recognize as foreign, any type of stress that the body's going under, any type of invaders. It's all going to impact the immune system, and it's all going to cause the immune system, essentially different responses, to become activated. I think usually when people think about the immune system, they think of response to infection, such as bacteria, viral, fungal. That's definitely the case, but it also plays a role in cancer and our body's reaction to cancer, adaptation to cancer. Um, it's important to note too, the immune system is involved with so many different physiological processes that occur that we easily take for granted, such as digestion, neurological function. Different players within the immune system, different white blood cells, for example, are continuously involved in those processes. And so it's very common that if you have a weakened immune system, these other systems within the body are going to also pay the price for that. something that I think is really important for us to consider here, just in general, is that when we often think of the immune system, we think that it has the capacity to protect and heal the body. And it certainly does, whether that's a splinter, whether that's a bacterial infection, whether that's a fungal infection. It also has the ability, though, to attack and damage the body. I'm sure many of you probably know someone who has some form of autoimmune disease, and that's exactly what it sounds like. It's a process, or it's a disease. There's many different types of autoimmune disease, but essentially our immune system, the players within it are hijacked, and they don't recognize ourself as ourselves in many instances. They recognize components of different cells within our body, different components even of our own immune system as foreign. And it's a very good evolved system, the immune system is. So when that message is received that something is foreign, even if that something is ourselves and it's not meant to be perceived as foreign by the immune system will attack it. And so to that extent, a lot of individuals who have a form of autoimmune disease, for example, have to take medications or measures that weaken the immune system to prevent it from attacking itself. It can happen on so many different levels, so many different components could result in autoimmunity, and really the treatment is incorporated in which aspect is being impacted. But just keep in mind, it can heal the body, but it can also attack the body. I think most people don't maybe realize that. It's important for us to consider as we move forward. Um, so I wanted to start with kind of the breakdown of the immune system. There are organs associated with the immune system. And essentially what we have is we have primary as well as secondary organs within the immune system. There's a whole host of different cells, especially white blood cells within the immune system. And these are kind of always floating around in our body to some extent, and they're the key players in different immune responses for our body, but they have to come from somewhere. And so the primary organ or examples of the primary organs, the main ones are the bone marrow and the thymus. These are locations really where different types of lymphocytes, which is essentially a type of white blood cell, they'll proliferate. And so for the bone marrow, it's mostly associated with B cell production, B cell proliferation, whereas the thymus is really associated with T cells. B cells and T cells are very much different from one another. As we go through this 4 lecture part series, we're going to know all about B cells and T cells. So don't worry about that. A great mnemonic for remembering this is to associate the B in bone marrow with B cell and the T in thymus with T cell. So it's always an easy way to remember it if you get confused. The secondary organs that we talk about for the immune system are predominantly the spleen and the lymph nodes. Secondary organs are really where mature lymphocytes can kind of pool, proliferate, and then move on to provide a response. And if you pick up on that word mature, it's really important here. When we look at our immune system, we're going to see that there's aspects of our immune system that are associated with memory, some that are not, and some that have mature cells and some that don't have mature cells. But essentially, if we're looking at these primary organs and comparing them to the secondary organs, the primary organs are going to be where they are kind of created, where they proliferate. The secondary organs are going to give these cells from the primary organs the chance to interact with the rest of the body, and they interact with antigens that we might come across. So the 2 most noteworthy examples of secondary organs within the immune system are the spleen and the lymph nodes. So, as I was saying, this is a topic that's filled with vocabulary. So there's a confused owl, and in case you're confused. And so I wanted to go into some of that vocabulary right now. If this is your first time coming across some of this information, it's probably confusing. I definitely suggest, as I was mentioning in the beginning, going back to the book, going back to the course compendium, reviewing the vocabulary, really until you become comfortable with it. Give it a day, go back to it again. There's tons of studies right now with memory. What makes us able to remember things? Really, they find that the first time you receive a piece of information, it's very transient, the amount that it stays with you. If you spend 24 to 36 hours reviewing that, it's even stronger. But then if you give it a break, like 24 hours, and then come back to it for that third time or more, that's when it can really, the information that you study can really become ingrained. And then what happens with that is you lose less and less of it moving forward, the more you kind of incorporate it into your studies. So that's just a good general topic for all the courses we're going to do, really. So some of the vocabulary here, if this is all foreign to you, a lymphocyte is really a non-specific type of white blood cell. There are many different types of lymphocytes. On the previous screen, we talked about T cells and B cells specifically. We're going to get a little bit more into T cells and B cells today and moving forward. As I mentioned before, this first lecture is going to be a groundwork, and then really in lectures 2 and 3, we're going to get into some of the different complex processes that occur within the immune system, how our body recognizes different antigens, how it deals with them. And then with the fourth lecture, we're going to go a little bit into immunodeficiencies. And so a T cell and B cell, like I said, there are two types of lymphocytes. The T cell can recognize antigens from different sources. As I was saying before, we usually think about a bacteria, a viral process, a fungus, but it can also be a cancer, and it can also be just a foreign body. When we have a splinter that goes into our hand, for example, this does activate the immune system. That splinter, proteins associated with that splinter are recognized as foreign. And so there is an immune system process that occurs even to just a splinter. When we look at B cells, they're more specifically associated with the adaptive immune response. Shortly after this, we're going to go into innate versus adaptive immunity, but for adaptive immunity, that's where B cells come in. B cells are really involved in production of antibodies. They're a type of protein that is paramount to the antigen antibody interplay as far as when we have this type of foreign substance. And so an antigen is just a common term for really anything. It can be a toxin, a bacteria, a virus, a fungi. It's any type of substance that may incite an immune response. You might come across the term pathogen as well. They're not exactly interchangeable, but a pathogen is more like a bacteria, a specific virus, a fungi. That's what we mean when we say pathogen, whereas antigen can be also a toxin. It can also be a splinter. When we talk about antibodies, these are proteins that are produced specifically by B cells, and they provide protection from antigens. They're involved in the response against antigens. There's a whole complex interplay between antigens and antibodies that, again, lectures 2 and 3, we're going to spend a lot of our time becoming comfortable with a few of the different processes that occur. Okay. And so now, and when we talked about the primary organs, the secondary organs, we talked about the bone marrow. And now we're going to talk about the thymus now, though. The thymus is one of the primary immune system organs. It's mostly involved with with T cells. It's a location where T cells can differentiate. They can also mature. The thymus is located kind of right in the middle of the chest. A little bit to the left, but it's called the anterosuperior mediastinum. It's kind of just a little bit to the left there. On chest X-rays, sometimes you can see what's called a thymic shadow. It's the location where you can actually see the thymus. It looks like almost like the sail of a sailboat. And when we look into the thymus, it really consists of a cortex and a medulla. The cortex is the inner part. It's where we have immature T cells. Whereas the medulla, again, M for M here, it's an easy way to remember it. We have mature T cells. And kind of some trivia here. I'm going to talk about something really quickly called the George syndrome. Some infants are born without a thymus, and a common case of this is in DeGeorge syndrome. And so the homework, maybe for brownie points or something, is if you can tell me why DeGeorge syndrome is associated with the phrase catch 22 next week, or if you email that to that email address I sent you, that would be great. I'd love to hear that, but that's just extra. But when we look at this situation, what would happen if an infant's born without a thymus? We're saying this is the organ where T cells will differentiate, where they mature. It has immature and mature T cells. So you can imagine if in DiGeorge syndrome, when an individual, an infant, doesn't have a thymus, the outcome of that is brutal. There's going to be infection throughout the body. The body then won't be programmed through that organ to have as robust of an immune response. And one of the features of DiGeorge syndrome is infection very early in life. Infections that the body is able to handle, but without the thymus, we're lacking a key player in promoting that immune response. So that's an interesting little clinical correlate there. The other one of the secondary organs we talked about was the spleen. The spleen is, I think everyone always associates it with red blood cells. I had a professor who once told me the spleen is where red blood cells go to die. It's true, but the spleen is also associated with the white blood cell response. So it's located within the left upper quadrant of the abdomen. It's in front and lateral to the kidneys, which we call anterolateral. And just in general, when we look at the abdomen, when we discuss it, it's composed of different quadrants. We have a right upper quadrant, we have a left upper quadrant, we have a lower left quadrant, we have a right lower quadrant. When we talk about regions, it's even more specific. There are 9 regions within the abdomen, but the spleen is one of the main organs that's within the left upper quadrant. When we look at the right upper quadrant, for example, literally as it sounds, just under your rib cage, the primary organ we have there is the liver, also the gallbladder. So it's just a way to discuss the location anatomically and where we can find different different organs. And just real quick, a note too, you'll see words in the previous slide, you saw anterior superior. Here you see anterolateral. They are just what they sound like. Anterior means the front, posterior means the back, and lateral means lateral to the periphery, to the outside, whereas medial means medial, meaning the midline. So it sounds like complex vocabulary, but it really isn't. In that sense, when you see anterolateral, it's just meant to tell you it's in front of and lateral to the kidneys. So the spleen, the way it's organized is we have what we call different sections, but specifically we have areas of red pulp, white pulp, and the marginal zone. Thankfully, they're named specifically for the purpose. Red pulp is the vascular segments. And within each spleen, obviously, you have all these components. The white pulp, however, is predominantly composed of T cells. It's within a part of the spleen called the periarteriolar lymphatic sheath. Okay, just sometimes people call it the PAL. But there's T cells that are within that sheath, but then we also have B cells, which are within the follicles of the white pulp itself. So you can see the spleen is really associated with both T cells and B cells. But then we get to the marginal zone, and the marginal zone is a little bit like the highway of the spleen, if you will. It's an area between the red pulp and white pulp, and it contains a lot of macrophages, actually. Within the macrophages are a type of white blood cell. And the marginal zone is really rich in macrophages as well as antigen presenting cells. Antigen presenting cells, again, back to the vocabulary, it's exactly what it sounds like. It are cells that are basically programmed to capture and present antigens. Because, before we talked about different infectious sources, different things such as maybe a splinter. So there's actually proteins, what these antigen presenting cells will do is there's different proteins that are associated with, for example, the splinter. There's bacterial proteins. The antigen presenting cells will capture them and then present them to different parts of the immune system. It's within that presentation that the immune system can say, oh, well, hey, this is not supposed to be here. I have to take care of this. I got to do my job now. I have to mount an immune response to kind of deal with this foreign substance, this invader to the body. And so the marginal zone is very, very rich in those splenic macrophages as well as the antigen presenting cells. So really that organ in that left upper quadrant, the spleen, is really important for the immune system and the immune processes. So I wanted to go into a little bit of a clinical correlate here. It's just really interesting. It involves the spleen and sickle cell disease. For any of you who are not familiar with sickle cell disease, it is an inherited disorder, which means it's genetic. It comes with a genetic variation in some of the proteins on red blood cells. And essentially what happens is that in sickle cell disease, our normal red blood cell is nice and round. It has the look of a sphere. In someone with sickle cell disease, they have round red blood cells, but when they come under stress, that can be physiological stress, decreases in pH, which means a more acidic pH, or hypoxia, which means lack of oxygen in the blood, which usually comes with stress, high altitude. What happens is that due to the genetic variation and the genetic coding of the red blood cells missing the valine part of the red blood cell, the red blood cells can actually become hard. They can become a little bit sticky, and they revert to a sickled shape as opposed to a round shape. So they kind of become like a crescent-looking moon, or that why it's called sickle cell disease, that sickle um, shape itself. So if you can imagine, you have red blood cells, millions of red blood cells coursing through your body. What happens if they become hard, sticky, and sickle shaped? They get stuck when they're moving through different areas. They get stuck. They're less able to carry oxygen. They're really less able to do their time, to do what they're meant to do, I mean. So over time, though, when you have, especially if you have increased, we call them sickle cell crises, that's when an individual undergoes this type of stress, this hypoxia, decrease in pH, and you get that sickle shape. Over time, if they're going through the spleen, for example, they can cause a lot of scarring and they can cause atrophy, or what's known as basically a death. Part atrophy is like a self-destruction of the organ. And in medicine, we call this autosplenectomy. Autosplenectomy in sickle cell disease is very common, especially over time when there's more and more crises. The spleen just can't keep up. It's a smaller organ, and really these sickle shaped red blood cells just kind of tear up the spleen over time. Excuse me. And what's important here is that if we have this condition of autosplenectomy, which essentially the spleen within the body becomes smaller, becomes scarred, it becomes unable to do its job. It basically becomes as though you didn't have a spleen. Excuse me. What's important about the spleen, though, is I was referring to the splenic macrophages in the last slide. And what these do within the spleen specifically is that these macrophages within the spleen are involved against our reaction to certain types of bacteria, specifically encapsulated bacteria. So if we have one of the most common ones is, of pneumonia. Everyone's probably heard of pneumonia. It's a particular bacteria called Streptococcus pneumococci. It's encapsulated, which means it has kind of a capsule surrounding the bacteria that makes it a little bit more harder for the immune system to kind of eradicate when we do have pneumococcal infection. But what happens in patients with sickle cell disease is that after autosplenectomy, their spleen just basically does not function as well. It doesn't really function at all. And what happens is that these splenic macrophages then can't do their job when it comes to these encapsulated bacteria. So there's a whole host of encapsulated bacteria. Another common one is meningitis. So if you have a patient with sickle cell disease, regardless of what treatment you're giving them, always just make sure that they are taking some sort of vaccinations or are staying on top of their health. Because what happens is that in patients with autosplenectomy, these encapsulated bacteria can just wreak havoc on the body. If they're not kept in check, the individual will suffer from infections from different encapsulated bacteria, and some of them, especially such as the meningitis, as well as H. influenzae, can be very severe. An individual can die from those without question, and rather quickly too. So the takeaway, if they have sickle cell disease, this is a little bit of how sickle cell disease, the crises, the effect on the spleen works. But the takeaway here, the clinical takeaway, is that if you have a patient with sickle cell disease, just always ask them, encourage them to stay on top of their vaccination history, just because if they are at the point where their spleen isn't functioning, they can be in serious trouble. And autosplenectomy is also something that can happen really, really quickly, you know. I saw your hand, Christina. Did you have a question?
Can you hear me?
Yeah.
Sorry, I don't want to interrupt for too long, but I did wanted to ask you if something like sickle cell, can that go undiagnosed, or is that typically like pretty obvious with the findings of the symptoms and everything?
No, it definitely can go undiagnosed. There's always a potential for that. But a lot of times there is a family history of it. So a lot of individuals will know to some extent because someone in their family had sickle cell disease. Um, One of the common manifestations too is these crisis episodes that I was talking about. The pain in them is very severe. And a lot of that pain is caused by this sickling. When the blood flows, even in bone marrow, it can lead to incredibly intense bone pain for that reason. The pain is
Mhm.
actually so severe in sickle cell disease that a lot of individuals take opioids, different types of opioids for the pain. It is that bad. And to that extent, unfortunately, it has led to some issues with um, providers being unsure because opioids are very powerful medications. They're also substances of abuse. Unfortunately, throughout the years, it has led to kind of a conundrum for providers. Is this a patient who's just seeking opioids, or are they really undergoing a sickle cell crisis that requires the medication? But to answer your question, it can be undiagnosed, most certainly. It's especially because it's a genetic inherited disease. But the thing to look for is any family history of it. Is there a family history of someone who's had these kind of bone crises and this significant pain, really? There's other findings you'll have like sausage shaped digits, for example, just because of the impact of the red blood cells going through capillaries in your fingers. But a great question. I think with anything, you always have to have what we call clinical suspicion, meaning, it's your job, any provider's job, really, to never assume, to always try to find out as much as possible, because the moment you don't do that, your patient's the one that could pay the consequences for that. But a great question for sure. All right, so moving on from that, which we probably spent the most time in so far, I'm going to go to lymph nodes now. I think everyone's probably heard of lymph nodes to some degree. We have clusters of lymph nodes really located throughout our body. And they're a key player in the immune response as far as in the immune system activation and the circulation of T cells and B cells. So for example, we have clusters in so many different areas. The one I'm going to refer to in a little bit is especially the axillary lymph nodes. Axilla means right below your armpit, essentially. And that's a very common cluster of lymph nodes that's associated with breast cancer, for example. So those lymph nodes, for example, the axillary ones, will drain that area. And one of the areas that leads into that is the breast. And when I say drain, what I mean by that really is that lymph nodes are essential for the circulation of T cells and B cells. These white blood cells are always going through lymph nodes, and that's what I mean when I say drainage. It's lymph is kind of like we have blood as a fluid within our body. There's certainly water, but there's also lymph. Lymph is a fluid in and of itself, and lymph circulates through these lymph nodes, and lymph carries as in addition to a whole bunch of different proteins, it carries all these T cells and B cells. Um, and so when we look at the organization of lymph nodes, there's really three components. There's a paracortex, a follicle, and a medulla. The paracortex has these T cells in there, and it's really a highway for the T cells, the B cells to move in and out of the circulation. You'll have T cells that are going through the circulation, they'll go through lymph nodes and then kind of back out into the circulation as necessary. The lymph nodes, I kind of think of them as like a satellite center in a way. They're like a regrouping area where the T cells, B cells meet up, and then they go back out to the body. The follicle is associated with B cells. It's where B cells will congregate, they'll proliferate. And then the medulla, again, M for M, it has macrophages in there. And really, the medulla serves as this pathway, this communication pathway amongst different lymphatic tracts. We really have these lymph node clusters throughout our entire body, not just under the armpit. We have them in, our chest, by our thighs, in our head, under our neck, behind our ears, everywhere. It's this process of organization and communication, really, that makes lymph nodes special. And lymph nodes, can be infected by different disease processes in the body. For example, I'm sure everyone's heard of something called lymphoma. It's a cancer of actual lymph nodes within the body. So it's important to everyone always thinks of the primary organ systems, but lymph nodes, especially for immunology, are incredibly important. And it's important to keep in mind that they can be impacted by disease processes such as cancer, for example. Um, yeah, and I think I probably mentioned a lot that I did on this slide just previously, but these are the clusters again that I was talking about. They're located really everywhere. And what's key is that I gave some examples that we have, for example, lymph nodes behind our ear. We have lymph nodes in our armpits. What they will do is the lymph nodes will drain the structures or any organ system that's nearby. We have to think of it all as this like fluid communication. And when I say fluid, I mean actual fluid. And so the lymph nodes that are located in all these different areas within the body drain that fluid, communicate with that fluid. I know we're going into a lot of kind of anatomy today and organization like that, but I think it's important because when you're out in practice somewhere, whatever it is that you're doing, um, you have to have a degree of understanding of the language, in my opinion. And so this is kind of the basis for that. This way, when someone talks about a patient's spleen, when someone talks about lymph nodes, you're able to have an understanding of really what they're talking about, where they're coming from, even if they're going into it with a level of complexity that is beyond your understanding. Having that basic understanding can often see you through the conversation. So when we go to lymph nodes and the body, there's two notable ducts within the body. There's the right lymphatic duct and the thoracic duct. And these both drain lymph from different areas. And really, it's this lymph that's circulating around is essential, like I was saying before, for many of the different organ functions within the body. So the example I was giving before was the axillary lymph nodes that we can find below our armpit. Um, these commonly drain the upper limbs and the breasts, for example. So we have axillary lymph nodes on our left side as well as on our right side, and they're in clusters. There's a lot of different segments of it. And the common association of axillary lymph node involvement is metastasis to these lymph nodes as a result of breast cancer. Metastasis is where the cancer has spread from any organ beyond that organ to a surrounding structure or area. And when patients are worked up for breast cancer, actually lymph node involvement is always looked for. Because like I said, whenever metastasis occurs, it means it's one of the worst possible prognostic factors for any type of cancer, because it means that for breast cancer, for example, it means that the cancer that was in the breast has spread beyond that tissue and now is in a completely different area of the body, such as the lymph nodes. So individuals who have, for example, mastectomies for breast cancer, they will always look at the lymph nodes to make sure the cancer hasn't gotten to the lymph nodes as well. And a lot of times, if it has, it's not only a worse prognostic factor, but they'll then remove that segment, that chain of lymph nodes as well. So I believe there's a really great picture in the book too, in your required text, which has an example of these kind of lymph node clusters and shows their organization a little bit more. So I'd encourage you to refer to that in case any of this is confusing, but pretty straightforward. Okay, now moving right along, we're going to talk a little bit about innate immunity and adaptive immunity. Everything else previously was kind of some groundwork. Now we're going to start to get into the real immunology part of it. When we look at the organization of the immune system, these are the two primary types of immunity, both innate immunity and adaptive immunity, and we're going to compare them with these next slides. Really, what I want you to take away about for the innate immunity is that there's no memory associated with this response whatsoever. The body has no memory when it comes to innate immunity. And innate immunity is often very quick. It can be robust as well. It's a rapid, non-specific response. What I mean by non-specific response is that it's not really programmed for any type of memory. So when you have an infection that, like a pneumonia, for example, If you look, every season there's new pneumonia vaccines, and part of the reason for that is because the different bacteria, the different strains change each year. Now, if they didn't, it'd be great because then our body can have memory for them. But if they change, it's more difficult for our body to have this memory. Um, but going back to innate immunity, it's just rapid, non-specific. Any kind of foreign element that's exposed to the body, this innate system is going to be triggered. And so there's many different examples of innate immunity. Just our skin, our the physical barriers within our body, different membranes. These are examples of innate immunity. They provide us kind of protection from different pathogens. Other examples can include enzymes, natural killer cells, neutrophils, macrophages. Um, Associated protein that's very common is lysozymes. Lysozymes are actually found in tears. If you've ever found that you have something, a little particle stuck in your eye, it will cause tearing. Part of that is because it's the irritation involved, but part of that's also the immune system at work right there. If there's a little substance, a little particle that's in your eye, your body produces tears, and within those tears are lysozymes, which can break down different cellular components and is actually your body trying to protect itself. Um, Other examples of innate immunity include different cytokines as well as the complement system. And the complement system we'll get into a little bit, not today, but moving forward. These 4 lectures are going to go kind of in a systematic fashion, and 2 and 3 will be pretty meaty, if you will. As far as innate immunity and how it works, we have 2 players that communicate with one another. There's toll-like receptors, and then there's they're called pathogen basically receptor molecules, or PAMPs. And the toll-like receptors recognize different patterns of pathogens, such as those associated with bacteria, and prime the immune response. So if we look at a type of bacteria, we we categorize it as gram negative, as gram positive. There's different proteins associated with each, and these toll-like receptors will recognize elements of that bacteria to then initiate an immune process. And so while innate immunity is very quick and non-specific, no memory, adaptive immunity is exactly the opposite. Adaptive immunity is more of a very specific immune response, and it develops over the course of time. As it develops, it gets stronger and stronger with each activation of it. And that's because I talked about memory. And so what's important here is that there's memory associated with the response. And what that means is that if you have the same strain of a virus or bacteria that impacts you over time, with your first with your body's first encounter with that specific organism, your body's response to it is going to be a little bit slower and not as robust. Over time, over more interactions with that specific pathogen, adaptive immunity is going to kick in. The cells are going to recognize this invader. They're going to say, "Oh, wait, I dealt with this before." As a result, the response that your immune system creates is going to be a little bit stronger and a little bit quicker. Um, so that's what I mean by memory. When we look at microbiology, immunology, this is all impacted by the fact that we have different strains of the same bacteria or similar bacteria. We have different. I was using the flu for the flu virus, that every year it changes, and so that's something that kind of, it's this evolution of our body and the evolution of microbiology. A lot of these viruses change all the time. We see that commonly with COVID now as well. The spike proteins, when COVID first began, are completely different from the spike proteins today. And that even affects, the ability of the COVID vaccine to do its thing. But nonetheless, there is this memory associated, even if we take the spike proteins for COVID-19, for example, even though they're completely different or much different from the initial COVID strain, there's still elements of it that are similar. So that still allows our body to be primed a little bit more with this memory, the memory of this response. And adaptive immunity can really include components like B cells, T cells, and antibodies. If we look here, Earlier in the lecture, we were talking about B cells and T cells, but if you look at innate immunity, there aren't any B cells or T cells listed here. There are these other white blood cells, which we'll get into more as the lectures progress, such as natural killer cells, neutrophils, and macrophages, but those are just in this quick response. The B cells and T cells are more a component of the adaptive immunity, which is just a longer process. Um, and really, for the adaptive immunity, there's associated proteins, which include antibodies. Antibodies I referred to in one of the first slides when I was trying to build that vocabulary. It's the antigen antibody interaction, which we're going to spend a lot of time on next week. Um, and so like we have just a few slides left here. Like I said, this one's going to be one of the shorter lectures, just putting down the some of the foundation we're going to base everything else on. We're going to talk about the MHC, or the major histocompatibility complex. There's two. I found this to be very confusing, honestly, as a medical student. Pretty much all of immunology was confusing to me, but this is one where like you have to think about it, study it, take a day, look at it again, make sure it's still in there. So there's two MHC complexes that we're going to discuss. There's complex 1 and complex 2. And complex 1 and complex 2 are both involved in the presentation of antigens to T cells. But they work a little bit differently, and therefore different types of molecules. So again, just like innate and adaptive immunity, these two slides are going to be all about comparing and contrasting. When we look at MHC1, it's really any cell that has a nucleus in the body is going to have an MHC1 associated with it. It's in antigen presenting cells as well, and most platelets, but not red blood cells. It's an important distinction. So really, MHC is found in a lot of different cells within the body. MHC1 is associated with the CD8 subclass of T cells, a type of T cell, whereas MHC2 is associated with CD4, the CD4 type of T cell. One way I always try to remember it is that it's the rule of eights, meaning in one, if you multiply 1 and 8, it equals 8. MHC2 is going to be associated with CD4 cells, which I'll show on the next slide, but then 2 times 4 is 8. So it's a little mnemonic to remember that, all right, CD8 is MHC1, CD4 is MHC2. And so with MHC1, what it does is it presents antigens, any of those foreign substances, whatever it may be, bacteria, splinter, that are endogenous to CD8 T cells. And it means endogenous to the body, to the CD8 T cells. And what endogenous means is it means from the body. Exogenous, which we'll do on the next slide, really means originating from outside the body. And this is interesting. I always found this confusing at first. Viral antigens, such as the flu, COVID, are actually can be examples of something that's endogenous. And that's confusing because how could that be? We're getting a virus from somewhere else that originates outside of the body and then is coming into our body. It's not part of our body. Why is it endogenous? And it's because viruses replicate within our cells. So when a virus replicates within a cell, there's that part of that cell now is part viral and is part kind of coming from us, part endogenous. Whereas with bacteria, that's not the case. There's no replication like that within cells. The organisms, the colonies can grow, but they're not going into our own cells. And that's the key here. Viral replication is really, for our purposes of talking about MHC, an endogenous process. It's completely different from bacteria. When you get a bacterial infection and you take, for example, antibiotics, they're meant so that the bacteria don't replicate, so that the colony, the infectious source within your body, doesn't keep growing. The akin to that for viruses is that they replicate within our own host cells. So therefore, when we talk about the immune system and we talk about viruses, we have to think of MHC1 because they're replicating within the body, and that system, the MHC1 system, is going to present any type of antigen that really is endogenous to or coming from us. Again, different for bacteria. I'm going to harp on it again on the next slide too, because it is important and it's easy to understand when you're doing it, and then you're going to have a question or an exam, and then it's easy to get confused. But essentially how MHC1 works is different antigen proteins, different parts of the antigen, the protein components of the antigen are transported by different transporters associated with it and placed onto the actual MHC molecule. I'm going to begin next week's lecture with kind of a review of MHC 1 and 2 again, just because we're now getting into real immuno, and I'll have a picture that shows it. They have different chains associated with it, completely different looking structures from HC1 and 2, and that'll give you an understanding of how the antigen protein transfer and placement on the molecule is a little bit different for both of them. So key takeaway for MHC1 associated with CD8 cells, remember the rule of 8. 8 times 1 is 8. And then it's present in all these nucleated cells, meaning any cell with a nucleus, and it's going to be for presentation of antigens that are endogenous, meaning coming from us, to CD8 cells. Now, if we go to MHC2, the major histocompatibility complex 2, again, it's the same idea. They present parts of antigens to T cells. That part is not changing. However, what's changing a little bit is what cells within the body MHC2 is on, the type of T cell, the CD4 subset it interacts with, and the type of antigens it works with. So it's MHC2, whereas MHC1 was on all nucleated cells within the body, which is a ton of cells. MHC2 is only on antigen presenting cells, which means you're only going to find MHC on the cells that present antigens to different receptors. So the association here is, again, the CD4 T cells. That's what I mean by the rule of 8. 4 by 2 is 8, just as with MHC1, it's associated with the CD8 cells. 1 by 8 is 8. So easy way to remember it. I'm really big on mnemonics, and I think in immuno you need a ton of mnemonics. So I'm going to do my best to point them out as we go. Now, the difference here is that MHC2 works with antigens that are exogenous to our body. Exogenous antigens are then presented to the T cells. And really, again, like endogenous means from within the body, exogenous means from outside the body. So therefore, the common example here is bacteria. There's no replication inside cells of our own body. There's the growth of colonies, of units. And that's what differentiates, a key component that differentiates bacteria from viruses. But to that extent, when this is presented, when the bacterial components are presented, there's no confusion to the body. There's no part of our own DNA that's been replicated that's part of this bacterial presentation. So in that sense, you have to think of viral, MHC1, bacteria, MHC2. And so what it'll do is it'll be really, the endosome is an organelle within the body that processes a lot of different components, and the endosome will actually process part of that antigen presentation for MHC2. And so I think what I really want you to think of for MHC1 and 2 is just, yes, the type of T cells they're associated with, but more importantly, what cells they're on, and remembering what type of presentation they're involved with. Because all they're really doing is they're just taking parts of antigens, parts of invaders to the body, parts of foreign substances. Again, I go back to the splinter example. It can be a splinter as well. It can be, that splinter goes into your skin. There's going to be certain proteins on that splinter that are then imparted into your bloodstream that the body recognizes as foreign because they came from outside. Again, that would be an exogenous representation there. The viral situation is pretty unique. But really the takeaway that I want you to think about is, if we have these foreign invaders, such as antigens that are coming into our body, how are we presenting them to the T cells, to the B cells? And we looked at adaptive immunity. T cells and B cells were these players that had this long-term, robust response over time. They were part of the body's memory to different invaders. So how do we get from antigen, a foreign invader, to those components of the adaptive immune process? It's by the MHC molecules, MHC1, MHC2. And I think I've beaten that up enough over the head now, so I'll move on. And then this is our last slide for today. Again, I said today's lecture will be a little shorter than the rest, just because I don't want to start another I rather have the sections be all kind of inclusive, even if one lecture is shorter, just because once you can't really separate some of these like components lectures easily. But you might come across in some of your reading or your text the HLA molecules. What HLA is human leukocyte antigen. Um, and it can be confusing if you see MHC and then you see it maybe referred to later as HLA. Basically, what the human leukocyte antigens are is they're proteins found within so many different cells of the body. And again, what they do is it's the reason it's confusing is because MHC and HLA can be, even though if they refer to different things, can be used interchangeably, more or less within the literature. And to that extent, what the HLAs do is they do the same process. They take parts of this antigen, the peptides, for example, and they present them to their subset of T cells. It's really the same thing as MHC. So if you come across HLA, I don't want you to become confused by any means. It's very similar for our purposes. We can just think of them as the same. Um, and so within medicine, there are different HLA subtypes that are associated with different disease states. And this is interesting because we're going to come back to what one of the topics that I started the lecture with. A lot of times we think of the immune system as protecting the body, but a lot of times the immune system, if there's a problem somewhere, can also attack and damage the body. And so let's think about this. I'm saying that different HLA subtypes can be associated with different disease states. And so I give the example of HLA subtype DR4. That's a specific HLA subtype, just known as DR4, and it's associated with rheumatoid arthritis. We probably all know someone who has some form of severity of rheumatoid arthritis, very common condition, and it's an example of an autoimmune disease. And what it means is that our immune system is actually attacking itself. Very commonly in rheumatoid arthritis, you'll see the joints, the joints within the hands, for example, can become very large. There's a lot of destruction that's going on there by different immunological players, such as neutrophils, even macrophages. It happens over time. But so what we're saying here is that rheumatoid arthritis, part of what causes it to occur is this mutation or this problem with HLA subtype DR4 specifically. And what that means is we're saying that HLA, just like MHC, is involved with presenting parts of antigens to T cells. Within the subtype of DR4 associated with rheumatoid arthritis, there's a faulty process that's going on there. It's basically, this is the avenue through which rheumatoid arthritis is an autoimmune disease. It's by impact of this HLA subtype. Granted, it's not as simple as that, but it's, the basis for it. And so I don't remember if they're in your text, but you can always look it up. Again, this is a little bit nitpicky here, but there are tons of HLA subtypes, and each one is associated with either a common disease or a different form of disease. Some are associated with similar diseases. One can be associated with three. There's different disease states that can correlate different HLA subtypes as well. It's just really this is going to show the interplay between kind of disease processes and autoimmunity within the body. Did you have a question there?
I did. So
Absolutely.
I'm familiar with neutrophils and lymphocytes, but are leukocytes, are those another white blood cell?
Yeah, leukocytes are exactly that, a type of white
Okay,
blood cell as well.
thank
Uh,
you.
Absolutely. I'm gonna go. Oh yeah, see, do you say lymphocyte or leukocyte? You said leukocyte, right?
Leukocyte, yeah.
Leukocyte is really, when you think of leukocyte, it's just a white blood cell. That's how you can think of it. When you come to neutrophils and macrophages, they have different components that, like parts, uh, different aspects that allow them to do what they do. Neutrophils are usually like within our body's immediate reactions to any kind of invader. Macrophages are more of a prolonged, they're usually a little bit later on in that response process by the body. But leukocyte, yeah, if you think of leukocyte, you see leukocyte, just think white blood cell essentially. You
Okay.
can put it in parentheses, white blood cell. Absolutely. And really, as we go on too, there's going to be a lot more of that vocabulary that comes in. as we go. So that's why the vocabulary today is the easy foundational vocabulary. There's gonna be a lot more that comes in, but that's why I wanted everyone to have a good basis now going forward. And I think some of the most important things in this lecture really are even just talking about the thymus, the spleen, because really these are the things that people are going to talk about commonly, based on where your path with the university takes you. That's going to be the foundational language, the components that everyone's going to be using. So I want you to have good access to them, good foundational kind of instincts, so that when you're in that situation where you're having that conversation, you're able to follow along, you're able to like be part of it, as opposed to just saying, oh, what is that?
Yeah, no, for sure. I don't know if we were finished, but this was like I connected so many dots just by, I mean, first of all, the way you just you're amazing. You're an amazing speaker. So
Thank you.
getting the information out, it was just really easy for me to understand it, honestly,
All
the
right,
way
good.
you explained it all. So I appreciate that. Um and just with my own personal, especially this last year, I've had different things going on with my son. So a lot of this I already, like, I was familiar with because I've done a lot of research myself.
Hmm.
I'm already connecting so many dots and I've been to so many doctors that haven't done that for me. So it's just wild. Like, I don't know if you're still recording, so I don't want to go off on a tangent, but
Well,
um,
I'll stop sharing right now. Just finish the
okay,
lecture, and then we can talk some more.
okay,
But that's basically the end of today's, this first one here. We have three more coming up. We're gonna go into the forest, into the woods a little bit more. The next few. By the end, we're gonna finish talking about different immunodeficiencies as well. But definitely, just everybody, if you watch this, have this lecture kind of down, because it's just gonna get a little bit more complex, a little bit longer, a little bit more involved, moving forward. So, don't waste the time here. I want you to spend that time later on in the next, especially the next two lectures. And again, if anyone has questions, you can always email me um, at that Gmail email address I put up on the second slide there. And I know this stuff is confusing, so any questions you have, I'm more than happy to answer them and help. And that's it. And we'll catch up again next week. All right. Thank you.